Okay, everyone, we are back and we are officially ready to begin our presentation by Dr. Loren Cordain on hyperinsulinemic diseases of civilization, more than just the metabolic syndrome. So I am going to turn you over now to Michael Stroka.
Thanks so much, Sue. Welcome, everyone, and thank you for attending this evening's program. We have over 250 attendees, which is wonderful, and from points all around the world, including many in Europe who are staying up till after midnight to be a part of this. So it's really exciting to have you all here. As Sue said, I'm Michael Stroka. I'm the president of the American Nutrition Association. And first I want to thank Sue and Now University and Now Foods for their role in helping make this event possible. American Nutrition Association was founded in 1972, and we're a 501c3 charitable nonprofit with a mission to promote optimal health through nutrition and wellness education. And we do that through a variety of programs, such as our flagship lectures, as tonight's presentation. And over the years, we have had over 300 of these very high quality lectures from scientists from around the world, including Nobel laureates, Linus Pauling, Abram Hoffer, and a great many luminaries in the nutrition field, in which we include tonight's speaker, Dr. Loren Cordain. We also have an interactive website at AmericanNutritionAssociation.org, where there's a wealth of information and a great deal of interactive opportunities to learn and share. We have a newsletter that's been going for over 33 years, the Nutrition Digest, and we video record all of our events so that they can be viewed at a later date. You can see those oftentimes at our website and also on our YouTube channel. I want to thank every one of you who is already an ANA member for your support of the organization. And for those of you who are not yet members, I want to strongly encourage you to join the organization. Again, we're a charitable nonprofit, so it is through your membership and donations that we're able to bring these nutrition science luminaries and all of our other events and information to you. There are memberships that can fit every type: public, professional, student, and small business. So we would love to have you be a member of the American Nutrition Association, support the cause. Great information, a great cause. Upcoming events. So we've got some wonderful events coming up for this program year. October 31st is our annual symposium in Chicago, and it's held in conjunction with Natural Health Research Institute. This year's meeting is titled The Effectiveness of Natural Products and Integrative Medicine for Pain Management. And we have a phenomenal panel of 5 speakers coming and speaking for the day. In November, please join us for Dr. Deepak Chopra as he introduces his new book, What Are You Hungry For? In early 2014, we have a webinar on legislative activity as it relates to your ability to engage in the practice of nutrition. And so all nutrition professionals and aficionados should be a part of that to learn about the legislative landscape. Then later in 2014, Dr. Kulreet Chaudhary, an acclaimed neurologist from Scripps Hospital, will speak on the concept of Ayurveda. And so please check our events page at AmericanNutritionAssociation.org for more information on these and more programs that we have upcoming. Now, for tonight's lecture, we are extremely fortunate to have Dr. Loren Cordain lecturing on hyperinsulinemic diseases of civilization, more than the metabolic syndrome. Dr. Cordain is a professor in the Department of Health and Exercise Science at Colorado State University and is the world's leading expert and founder of the Paleolithic movement in nutrition. His research emphasis over the past 20 years has focused on the evolutionary and anthropological basis for diet, health, and well-being in modern humans. Dr. Cordain's scientific publications have examined the nutritional characteristics of worldwide hunter-gatherer diets, as well as the nutrient composition of wild, plant, and animal foods consumed by foraging humans. Using ancestral dietary characteristics as an organizational template, Dr. Cordain and colleagues have made unique contributions to our understanding of optimal diets for contemporary people. Dr. Cordain is the author of more than 100 peer-reviewed publications. He's the recipient of the Scholarly Excellence Award at Colorado State University, as well as the American College of Medicine's Denham-Harmon Award for the most influential scientific paper in 2004. He has lectured extensively on the Paleolithic nutrition concept worldwide and has written 5 popular books: The Paleo Diet, The Paleo Diet for Athletes, The Paleo Diet Cookbook, The Paleo Answer, and The Dietary Cure for Acne. Dr. Cordain has graciously agreed to take questions, as Sue mentioned after the presentation. and she'll be collecting those at the end of the presentation and having him answer them. On a personal note, I just want to say what a pleasure it is for me to have Dr. Cordain with us at ANA again, as I use the paleo diet to great effect in my own life and for my own health. And so he's truly one of my personal nutrition heroes. I brought him out to Chicago 4 years ago to do a set of lectures for ANA and had the exquisite pleasure of being able to spend the afternoon with him strolling around the Frank Lloyd Wright home here in the Chicago area and seeing a lot of the Frank Lloyd Wright architecture, of which he's a fan, and just really getting to spend time with one of my nutrition heroes. So it was an absolute thrill. And there are truly only a few select nutrition scientists that have truly shifted the paradigm in the field of nutrition, and Dr. Cordain is one of them. So we are truly privileged to have him with us here tonight. Welcome, Dr. Loren Cordain.
Hey, Michael, thank you. That was just an absolutely wonderful introduction, and I'm so appreciative of it. You're a great guy, and I want to welcome everybody. You've been patient. There's been a little bit of technical glitches going on, but I want to welcome everybody from around the world. And the only thing I would rather have would be to see you as an audience face to face, and we could meet in a great big auditorium. And right now here in Colorado, it's a little bit after 6 o'clock in the evening, and I know that many of you are tuning in from all over the world and all over the United States. So thank you for your patience, and this hopefully is going to be a good show, and at the end we can talk and we can interact, and it should be beneficial for everyone involved. Now let me tell you a little bit about this topic before we jump into it. This is based on a scientific paper I wrote in 2002, and at the time, in 2002, people talked about the metabolic syndrome, but the metabolic syndrome was also known as Syndrome X. And at the time, in the early 2000s, when this syndrome was just being recognized, we knew that people that had this syndrome had one or more of the following diseases. They were hypertensive, meaning they had high blood pressure. They had elevated cholesterol and other blood lipid abnormalities. They tended to be at risk for cardiovascular disease, and they were obese. And so this was kind of the collective symptoms that seemed to occur. And people had multiple diseases. They had a single disease and so forth. And so what we did at the time, almost a decade ago, is we extended this metabolic syndrome to a variety of diseases that at the time it was absolutely unheard of. And so that's really what I'd like to do, is to explain to you what the metabolic syndrome was a decade ago, and then fast forward to 2013 and show you the insights that we had a decade ago in that the metabolic syndrome and insulin resistance, and that's actually what the term hyperinsulinemic means, is that when insulin is elevated chronically, it produces disease. And so we think it extends beyond those 4 or 5 diseases that had been identified in the early 2000s and late 1990s. So let's go ahead and get started with it, and let's just look at some definitions. In the United States, we have the National Cholesterol Education Program, which defines the metabolic syndrome, and over here we have the World Health Association, which also defines the metabolic syndrome. And if you look at the number of symptoms in the NCEP, you can see what they are. You've got this on your screen. Fasting glucose of greater than or equal to 110 milligrams per deciliter. Abdominal obesity, so you can see that right here, with elevated waist girth. And characteristically, the blood lipid levels, high triglycerides, low HDL cholesterol, and blood pressure is typically elevated. The World Health Organization identifies these same factors, and they're slightly different, but for the most part, it's the same. Now, this data, you can see, appeared in the Journal of the American Medical Association in 2002, and for the most part, these landmarks of the metabolic syndrome have not changed. And so in the United States, about a decade ago, again in the Journal of the American Medical Association, if we look at the prevalence of the metabolic syndrome, and this is from the National Health and Nutrition Examination Survey 3, so this takes us up to 1994, which clearly is 15 years in the past, and I'm going to show you the recent data. 47 million adults in the U.S. had the metabolic syndrome. And you can see then, as we get older, most people that are in their 20s and 30s, the prevalence of the metabolic syndrome is fairly low, but by the time we get into our 40s, 50s, 60s, and 70s, you can see that many people have the metabolic syndrome. And if we look at the prevalence of the diseases that are associated with the metabolic syndrome, these are the symptoms: abdominal obesity, high blood triglycerides, low blood HDL, high blood pressure, and high glucose. So once again, this is about a decade old, and it shows the prevalence of men and women at this time period. Now, one of the most disturbing statistics that comes out of this same study shows that about 70% of all adult Americans, whether they're white, black, Hispanic, or from other racial groups, 70% have one or more symptom of the metabolic syndrome. So basically what it tells us is the entire population is essentially sick. The entire population in the United States has chronic disease that is related to diet. So let's fast forward. Let's get to the present now. Let's look at the prevalence of the metabolic syndrome in the decade since that last study was done. This is the NHANES data from 1999 to 2010. And if we look at the metabolic syndrome, it's decreased slightly overall for the entire adult population. You can see there's been a subtle decrease here. And these are the symptoms of the metabolic syndrome: high triglycerides. They've come down about 10% percentage of the population. Blood pressure has come down, but lo and behold, waist circumference has gone even higher, and blood glucose has gone higher. So the best interpretation, this study came out of the Journal of the American College of Cardiology in 2013, and what it tells us is that, yes, we've improved certain of these external symptoms of the metabolic syndrome, but they've primarily occurred because people are going into their physicians and they're using antihypertensive and blood lipid modifying drugs to reduce the triglycerides, to reduce the blood pressure, and so that's probably what's going on. And paradoxically, people are doing the same things from a dietary and exercise perspective that caused the problem in the first place. And so that's reflected in they continue to get fatter and fatter with high waist circumferences, and their blood glucoses are still completely out of control. So, yes, we've got certain pharmaceuticals that can mediate some of these effects, but we're still doing the same damn things that we were doing beforehand that caused the problem. Now, if you look at the classic diseases of the metabolic syndrome, most of you, I'm preaching to the choir, most of you realize type 2 diabetes, high blood pressure, coronary artery disease, and dyslipidemia. If you go in and get your blood lipid measured, what you find out, if you got the metabolic syndrome, your HDL cholesterol levels are lowered, you've got high triglycerides, you've got elevated VLDL, very low density lipoproteins, elevated small dense LDL, tend to be obese, and gout was actually recognized early on by Gerald Reeven's group way back in 1995. So what we did is we extended these classic diseases of the metabolic syndrome to additional diseases, and I'm going to show you what those are here in just a minute. All right. In the U.S., as in Australia and in Europe, and I know we have many European and Australian listeners, if we look at the 5 leading causes of death, you can see that cardiovascular disease is number 1, and regardless of where we are in the Western world, that takes out most of us. clearly cardiovascular disease is diet-related. Cancer is number 2, and most cancers are cancers that are called epithelial cell cancers. The leading cause of death with cancers are lung cancers, and clearly that has to do with smoking. But after smoking, we have epithelial cell cancers, breast, colon, and prostate. These are all related to diet. Accidents in males are number 3, and respiratory diseases, you can see here, this has to do with smoking. Diabetes is obviously diet-related. And so if we total all the diet-related deaths together, at least in the United States, it is the leading cause of death in the United States. Now, when we look at the metabolic syndrome, the pioneers in the field, DeFranzo, Reven, and colleagues, way back 20, 25 years ago or more, they recognized that these diseases, type 2 diabetes, hypertension, dyslipidemia, coronary artery disease, and obesity, in all of these diseases, we found insulin resistance. So let's take a look at insulin resistance and see what it is and how insulin resistance is related to diet and how it tends to predispose us for all of these diseases. So the largest organ in our body is our muscles, and muscles comprise around 40% of our total body mass. And when the muscles become insulin resistant, then what happens is that they don't respond to insulin from the pancreas. And when that happens, is blood glucose tends to rise. Now, even though muscle is the major organ of the body, all organs end up becoming insulin resistant when the same phenomenon occurs. In other words, when the muscles are saying, hey, look, we don't want any more glucose, we've had plenty of glucose, let's become resistant. Same thing occurs in fat tissue and in liver and in endothelial cells. Endothelial cells are the cells that line arteries and cells in the gastrointestinal tract and other cells. So virtually all cells in the body that take up glucose, which almost everyone does, tend to become insulin resistant when this whole process occurs. So here's the thing. It's really a simple concept. And what happens is muscles say, hey, look, we don't need any more glucose. We've got plenty of glucose. We are totally full. It's like after a Thanksgiving dinner. We've had enough. We don't need any more sugar. We are done. And so there are receptors that I'll show you here in a minute. And when this happens, when the muscle says, hey, look, I don't want any more glucose, then glucose spills out into the bloodstream. And when this happens, we have feedback mechanisms in our body that tells our pancreas, look, blood glucose is high. You need to secrete more insulin. And what insulin does is it drives glucose into the muscle. And so what's occurring then is that the body wants to maintain normal blood glucose levels, because glucose, if it gets too high, causes all kinds of problems. If it gets too low, we also have mechanisms that come into play. So when glucose gets high, when the muscles say, hey, no more, I've had enough, then pancreas secretes more and more and more and more insulin. And what happens is it drives the glucose back into the muscle, and now we are maintaining normal glucose metabolism in bloodstream at the expense of higher insulin. And this is called compensatory hyperinsulinemia, and this is fundamentally what underlies all of these metabolic disturbances that we see in the metabolic syndrome. So I don't want to get into a whole lot of complicated biochemistry here. Let me just actually go back, and we'll just kind of run through this rapidly. For those of you that are interested, you can see these references here, and you can copy them down, and you can follow through these pathways. But there is a protein called GLUT4, and what GLUT4 does, and you can see it right here, these GLUT4 is a protein that's formed in vesicles within the cells of muscles and other tissue. And what it does, it's a glucose transporter. And so you can see then that it comes to the surface, these little blue cylinders. It's formed in a vesicle, and it comes to the surface. And when it's at the surface, then it encourages glucose to come into the cell. And what regulates the input of GLUT4 to the surface of the cells is insulin binding the insulin receptor. And when insulin resistance occurs, what we see is that the normal concentration of glucose in the cells as well as glycogen is reduced. And that's the cell simply making a statement to the rest of the body that we're done. We've got too much glucose, we've got too much glycogen, we don't want any more. And so that's the fact, that's what is going on. And metabolically, what we see are defects in the trafficking of GLUT4. So GLUT4 doesn't seem to operate properly as it moves from the inside of the cell to the surface. It's not that the surface numbers of GLUT4 have been reduced, it's the trafficking, it's the way in which GLUT4 moves to the surface. And this is the pathway, and I'm not going to go through it. But the bottom line is what causes this problem with GLUT4 trafficking comes from too much fat or intramuscular triglyceride in the cell. So that's what starts this whole process, is the cells take in too much triglyceride or fat. And the bottom line for most of you that are out there listening to this broadcast is insulin resistance underlies all 4 or 5 of these diseases that chronically affect 70 or 75% of the population. And really what's more important than these biochemical pathways from a practical perspective is what in the world causes insulin resistance. So these are the proximate causes. And the first thing that we know, and it's been known for, 25 or 30 years, is that when blood glucose is chronically elevated, when your blood sugar levels are high all day long, it tends to cause insulin resistance. When your blood insulin levels are chronically elevated, it causes insulin resistance. There's another component that we'll talk about, which is called non-esterified free fatty acids, and when they are elevated, it causes insulin resistance. And there's another mechanism. If you've been down to your local clinic and they've measured your blood lipids, there's a component called the very low density lipoproteins, and when they are elevated in the postprandial period and in the fasting state, postprandial means immediately after a meal, and also when you are not eating. So these blood measures cause insulin resistance. And when they were identified back in the 90s and early 2000s, the ultimate mechanism still wasn't understood. So if you go back to the previous slide, you can see that. So the question then comes up is, how do we chronically elevate glucose, insulin, non-esterified free fatty acid, and VLDL? Well, I'll tell you how you do that is by eating these types of foods. So here's pie a la mode, which I'm sure many people out there have had and enjoy. And the problem is not eating this once in a blue moon. It's eating this stuff every single day or day in and day out. And so these are known as high glycemic load foods, and they all tend to chronically elevate glucose, insulin, non-esterified free fatty acids, and VLDL. We see this pattern again and again and again. Now, let me go back to the previous slide. So let's talk a little bit about, and this is my colleague David Ludwig at Harvard, and so you can see this data is almost a decade old. It's been replicated again and again and again. Now, what are high glycemic foods? Again, I'm preaching to the choir. Most of you know what these are. What we do is we have our subjects consume a food containing either 50 or 25 grams of carbohydrate, and then after they consume the carbohydrate, we measure their blood glucose levels, And so say we're interested in lentils. We want to know what the glycemic index of lentils are. So we feed them a load of carbohydrate from lentils that is either 50 or 25 grams. We monitor it over a 2-hour period. We measure the blood glucose levels. And notice that lentils have a very low area under the curve. The area under the curve is small compared to when somebody eats pure sugar or pure glucose. And so that's really how we calculate the glycemic index. And if we look at almost all refined carbohydrates, for those of you, and I'm sure I'm speaking to many of the people out there, before you adopted Paleo, what you were eating were primarily and mainly these foods at many of your meals. Many of us think that Cheerios are healthy foods, but look at the glycemic index. It's at 74. And this is work from my colleague Jenny Brand Miller at the University of Sydney, and you can see that high glycemic load foods have a glycemic index of greater, or high glycemic index foods have an index of greater than 70. Here's medium, here's low. So virtually all cereal grains, take a look at it, virtually all cereal grains have high glycemic indices. And this is how we eat them. We eat high glycemic indices and we load on sugar on top of them, which makes a bad situation even worse. So the next concept to come up is the glycemic load, and this is actually even more important to my mind than the glycemic index. If you multiply the glycemic index by the carbohydrate content of a constant portion of food, and in this case, I believe you need to use not just a standard portion, but a constant portion. So I vary here from the American Dietetic Association and others because the playing field is not equal unless you use a standard amount. And lo and behold, look at the glycemic load of these foods. Here's a bagel, a granola bar, donut, white bread, and so forth. And so if you look at these foods then, it looks like that almost virtually all cereal grains have high glycemic loads. Now I've pointed out sucrose, this is table sugar, which has a high glycemic load, and I've pointed out fructose, which has a low glycemic load. We're going to examine those in just a second. If we look at dairy products have a low glycemic load, but an insulin index that's very similar to white bread, and we'll get into that in just a minute. So let me just go back and emphasize that. So dairy products have a low glycemic load, and I don't have that in this chart. I'll show you it on another table. So in theory, dairy products, because they don't raise blood sugar, they should be okay, but I'll show you that they do raise blood insulin levels. Now, if we look at fruits and veggies are healthful foods in terms of how they affect our blood sugar and our blood insulin, and contrast these numbers to what I showed you with refined and cereal products. And universally, they have low glycemic loads. You may read the South Beach Diet and tells you not to eat watermelon. No, that's not that's not true. Look at how low the glycemic load is with watermelon. Same thing with carrots. Carrots have very low glycemic loads. Now, we only get into trouble with these if we juice these and turn them into juices that have no fiber. So if we look at the per capita consumption of highly glycemic and highly insulinemic foods in the U.S. diet, you can see here that dairy has a very high insulinemic response, as do potatoes, and they also have high insulin responses. Refined grains are both high in insulin and glucose, and refined sugars are both high in insulin and glucose. So it's no wonder that two-thirds of the American population, as well as most of the Western world, have diseases of insulin resistance, because they're getting almost 50% of their calories from these highly insulinemic and highly glycemic foods. And going back, again, a decade to 20 years, this information was first recognized by my colleague David Ludwig and others, that high glycemic load carbohydrates have adverse effects on our blood lipids. They reduce the HDL, they elevate triglycerides and VLDL, they increase small dense LDL, and they're associated with all of these diseases of insulin resistance. So you would think then that at the time, 20 years ago, the public would have got the message. No, we didn't, because the government and the recommendations the government was making simply did not reflect the science as it was starting to develop. Here we are 20, 25 years down the road, and we're starting to get that message, but not completely. And so high glycemic load carbohydrates, the very first intervention studies, again done by Frost and Ludwig and so forth, shows that when you eat this versus eating this, it improves all of those blood indices. And so scientists from New Zealand and Australia, and I know we've got a few folks listening from down under, they worked out the mechanisms. These are the metabolic mechanisms. And so what happens is that when you eat high glycemic load carbohydrates, what it does, so let's start off up here, you eat high glycemic load carbohydrates, refined grains, refined sugars, and so forth. What it does is it causes the liver to increase VLDL, very low density lipoprotein. And what that does is it increases, and TAG is triglyceride, it increases triglycerides in the muscle. And that's the fundamental underlying problem with insulin resistance, is increased triglyceride in muscle. And when the muscle gets too much triglyceride, it goes, look, I don't need any more glucose, and that's when the GLUT4 receptor is fouled up, and it says, hey, look, no more glucose for muscle cells. We are done. It's like Thanksgiving dinner. We've had enough. So what happens then, the glucose spills out into the blood, and in response to that, the pancreas increases insulin secretion. So we now have normal blood glucose at the expense of higher insulin. And with higher insulin, then there's this cascading effect of increasing triglyceride in adipocytes or fat cells, and we have insulin resistance in fat cells, which causes increases in what are called non-esterified free fatty acids, which also tend to promote insulin resistance. Okay, so let's go back to the notion of fructose. And most of you realize that high fructose corn syrup has become, has overwhelmed the Western diet. We put it in virtually everything, soda pops and baked goods, and you name it, high fructose corn syrup is anything. However, if we look at fructose, look at this, my God. It contains a very, very low glycemic load. And generally, foods with low glycemic loads, we talk about fruits and vegetables and healthy foods have low glycemic loads, just like fructose. But it turns out that despite its low glycemic load, fructose is potentially problematic. And let me show you how that works. So if we look at the majority of the fructose in the U.S., the Australian, and the Western European diet, it comes as a mixture of three different types of fructose. There's high fructose corn syrup 42, containing 42% fructose and about 53% glucose. The second is high fructose corn syrup 55, 55% fructose, 42% fructose, and high fructose corn syrup 90, 90% fructose and 8% glucose. This was popular in the 90s, and they don't make too many foods with this anymore. Most of the foods then tend to come from high fructose corn syrup 42 and 55. Most of the soda pop is made with this one. And the reason they do it is because fructose is about 50% sweeter than sucrose. So to make a bottle of Coca-Cola, it costs half as much because you don't have to put nearly as much fructose to make it sweet as you do sucrose. However, table sugar is a mixture. It's a chemical mixture. It's actually not a mixture, but a compound. Table sugar, sucrose, is a compound with almost a high glycemic index, but upon digestion, you can see what happens to it. It's a disaccharide that's broken into two monosaccharides, glucose and fructose. So the question comes up then, is sucrose worse than fructose, or are they both bad? So animal experiments done by Jeff Thresher, he's a graduate student of Mike Pagliasotti actually here at Colorado State University have shown that what causes insulin resistance when you feed animals high amounts of table sugar is actually the fructose moiety. So let's go back to the previous slide, and you can see that when you digest sucrose, it has two monosaccharides, glucose and fructose. And so it turns out that fructose is what causes insulin resistance in rats. And we know that it also is what causes insulin resistance in humans. This is a very cool experiment done about a decade ago using hyperglycemic clamps and isotopic tracers, and it shows that you can take normal college students, and if you infuse fructose into their bloodstream, they immediately become insulin resistant. So scientists then, a decade ago, were trying to work out how in the world does fructose end up causing insulin resistance. Well, you don't need, even though this is kind of a biochemical pathway, let me just walk you through this very simply because we don't have to look at all these compounds. But glucose, this is a process called glycolysis in which we break down sugars and we turn them into ATP so that we can use them for energy for our muscles and our cells and whatever. And so glucose goes through this pathway very nicely, and there's a gatekeeper here called phosphofructokinase. And so when glucose goes through the pathway to end up producing ATP for our cells, this is the gatekeeper, and it doesn't allow glucose to come through the pathway uninhibited. If it starts coming through too fast, it slows it down. Fructose, on the other hand, enters into glycolysis beyond this gatekeeper pathway, and it can do as much of this as we want. If we throw in fructose into our bodies, bingo, it goes through this pathway, and it produces unregulated amounts of glycerol 3-phosphate and acetyl coenzyme A. Now, these are the two precursors that make what we call acylglycerols, and you know that better as fat. So acylglycerols are fat, and it produces a fatty liver. So you eat high amounts of glucose or fructose, it causes a fatty liver, and liver then secretes these VLDLs, which ends up causing insulin resistance. So fructose is a very unusual sugar in that it promotes fat formation. I call it fatty acid esterification. All you need to know is that when you eat sugar, it causes the liver to make fat, and when fructose gets to liver, it secretes these VLDL, which have triglycerides or fat that end up into muscles, and that causes insulin resistance. So when we look at high glycemic load foods, generally they're made up of this stuff, cane sugar or sucrose, and high fructose corn syrup. So both of these compounds, sucrose and high fructose corn syrup, tend to promote insulin resistance. Now the question comes up, and we have many folks out there that are very much interested in this because I'm sure that you're on the paleo diet, and one of the components of paleo is not to worry a whole lot about fat, and I'm in that same boat. So these types of meals, bacon and eggs for breakfast, lamb chops for dinner. At one time it was thought that if you ate too much of these fatty foods, these are the foods that caused insulin resistance. Actually, a series of studies from 1991 to 2001 showed exactly the opposite. They showed that fat simply does not, if it's in an isocaloric diet, meaning that you're not eating excessive calories, it doesn't cause insulin resistance. So you can eat all the fat you want and you won't become insulin resistant. Conversely, with high glycemic load carbohydrates, people tend to become insulin resistant very easily. And it's only when you overeat these food under hypercaloric conditions that you can become insulin resistant. And I'm going to show you in the very next few slides that it's difficult to become insulin resistant or to eat too much food when you're eating these types of food and you're not eating refined carbohydrates. So the real disaster is to eat these along with high glycemic load carbs. So how do we do it in the Western world? Well, here's a fatty meat. Here's a hamburger, which is pretty fatty. But the problem is, if we were just to eat the hamburger with the tomatoes and the onions and the lettuce, which are all low glycemic load, it wouldn't adversely affect insulin metabolism. But when we throw in French fries and the white bread, we have a problem. Same way over here with the pizza and Coke. This is just an awful combination. You've got cheeses, you've got fatty meats, you've got refined carbohydrates, high fructose corn syrup. This is an absolute disaster in terms of what it does to our insulin metabolism. So the bottom line is that when we look at the foods that tend to promote insulin resistance, they're both high in fat and high in glycemic carbohydrates. This is a combination that you never, ever see in nature. I defy any one of you to tell me a food, a natural food, that is both high in fat and high in refined sugars or carbohydrates. But yet these are the foods that we are very much interested. These are our comfort foods. These are the foods that make us fat. So it's impossible to get fat on steamed broccoli and salmon, but you can easily get fat on over-consuming these types of foods. So you can see here's a Mars bar. Look at that, 45% fat, 52% refined carbohydrate, very high glycemic index. Ice cream, another food that is a disaster, high fat percent, high carbohydrate percent, and high glycemic load. What's another one? Potato chips, corn chips, and salsa. Isn't that a favorite in the United States? So if we look at the classic diseases of the metabolic syndrome, type 2 diabetes, heart disease, dyslipidemia, elevated or triglycerides, lowered HDL, so forth, high blood pressure and obesity, it's almost certain that these are the types of food that are staples in the Western world that tend to promote these diseases. High glycemic load foods, as well as foods that have high fat content. A very abnormal combination of macronutrients. All right, so here's where we're going for the next 15 or 20 minutes. We started at about 6:15. I'm going to try to finish you guys up at no later than 7:15, and then we'll open it up for questions, and hopefully I can finish it up in another 10 or 15 minutes. So what our research group was interested in is that we knew that these kinds of foods were responsible for promoting diseases of the metabolic syndrome. And it's almost without doubt in 2013, very few nutritionists, physiologists would suggest that regular consumption or overconsumption of these foods don't contribute to the metabolic syndrome. But what is less well appreciated, let me go back to the previous one. What is less well appreciated is that these foods also contribute to a variety of other diseases that we believe are also part of the metabolic syndrome. And so we're going to go ahead and look at a trend for increased stature and reduced age of menarche in the last 200 years, myopia or nearsightedness, acne, polycystic ovary syndrome, breast, colon, and prostate cancer, skin tags, a skin disease called acanthosis nigricans, and I'll show you what that is here in a minute, and even something as frequently seen in the Western world as male vertex balding. So let's take a look at all these diseases and see how insulin resistance may be related to these and how diet is directly affecting the incidence of these diseases. So the first thing I want to consider is what we call the secular trend in stature and age of menarche. So secular means something that's happened over time. And if we look at stature in the Western world, in virtually all industrialized countries, stature has increased dramatically over the past 200 years. And in females, we see a concurrent reduction in the age of menarche, in other words, the age of the first period. And we also see the reduction in the age of puberty. It's just easier to market in females when we talk about menarche. So in the scientific literature, it's easier to document than it is in males. So when this little girl grew up in 1813, and this little girl grew up 200 years later, this little girl had an age of menarche probably around 14 or 15, and this little girl, in all likelihood, in all likelihood, will have an age of menarche between 11 and 12. Let's see how this happens. So before we do that, let's take a look at the secular increase in male height. We have good data from conscripts in England, so soldiers and Navy personnel and military people, when they were conscripted into the British military, we got their height and weight, and we can track it from 1888. The average soldier or military guy in 1888 was about 5'5", 5'6", and you can see by 1960 that male was about 5'9". And we have the same data from the Netherlands. So in Europe, you folks have taken very good data. And once again, we see from about 1860 till 1960, over this 100-year period, the height increased in males. In North America and the United States, we also see the same change in height over males from 1880, and this one just looks at a little bit differently across the lifespan. So by the time little boys are 2 or 3, they're actually taller and have a greater stature in 1960 than they did in 1880. And so the secular decline in menarche, the age of menarche, was first pointed out by an anthropologist by the name of Tanner, 1962, and he studied these women in 1962 and asked them basically, when was your first period? And they extrapolated back, and so the oldest women in the study were perhaps 90 or maybe even 100 years old, and they built what's called a regression line, and they regressed this data backwards in time. And what Tanner suggested, that the increase in the age of menarche occurred right around 1830, and it was about 17 years of age, and it dropped to about 12 by 1962. And as I'll show you here in a minute, after 1962, it dropped even further still. So this is just more epidemiologic study that support Tanner's data. Here's some data out of Iceland, where menarche declined from about 15 to 13.5 from 1900 to 1915. In Belgium, we see the same thing, except during the world wars, in which refined carbohydrates and sugars were rationed. And in rural China, where they didn't have access to Western foods until fairly recently, it dropped from 16.5 to 13.7 in 1960. So this is kind of the magic number here. This is probably the real number that we see for females in terms of when they should and biologically are programmed to have their first period. And all the rest of these numbers are an artifact of Western culture. This is my colleague Boyd Eaton's work, and he studied the age of menarche in unacculturated populations, or hunter-gatherers, like these Australian Aborigine women and her 2 daughters. And you can see then from this data, it looks like the average and the normal human age of menarche is about 16 years of age. Contrast that to the numbers I've just shown you, and you can see that it has dropped dramatically in the last 200 years. And so scientists have become aware of this, and they're really not sure what are the mechanisms that are involved. Some have suggested it has to do with diet, more protein, fat, or calories. Some say maybe we're cleaner, we have less disease, whatever. But the actual data has shown, the disposal data in the populations have shown that protein and calories really haven't changed a whole lot or declined or stayed constant. And prospective trials, what these are, is where you take girls that have not yet experienced their first period, and then you follow them through, let's say maybe they're 8 years old, you follow them through 3, 4, 5 years until they do, and then you administer them questionnaires to see if it's anything related to diet. And this very first study, done in 1991 at the Harvard School of Public Health, showed that it was unrelated to these elements that people had thought it was. So the question comes up, what really has changed over the last 200 years? And this is our data that we've used from other people that have analyzed it. And In England, you can see then that the per capita consumption of sucrose, starting in the very beginning of the Industrial Revolution, has increased dramatically. The average citizen was consuming less than 20 pounds a year in 1815, and by 1970, that number was up to 120 pounds. This is per capita consumption data from the Netherlands, and once again, you can see starting in right here at about the Industrial Revolution, about 200 or more years ago. Prior to that, the average citizen ate very little refined sugar, and once the Industrial Revolution kicked in, they were consuming more and more and more. And once again, by the late 1930s, they were up over 100 pounds. This is per capita consumption in the United States. We have data prior to 1909, and it looks similar to Europe. So if we go back to 1860, we're at about the same level as the Europeans were, but by 1900, we were up to about 90 pounds per capita, and it continued to increase, and it maxed out in about 2000. So we were at about 150 pounds per capita of all refined sugars, and then thanks to, I think, increased awareness of the adverse health effects of sugar, it's dropped a little bit in the succeeding decade. All right, one of the factors that I'm interested in, and you should be interested in, is when we talk about diseases of insulin resistance and the metabolic syndrome and beyond, one of the increasing factors in the diet that has changed dramatically is fructose. So when I was in my early 20s, there was virtually no high fructose corn syrup in the U.S. diet, simply because it hadn't been introduced. Starting in about 1980, we started putting more and more and more high fructose corn syrup into our diet. And you can see then what it did is it displaced the sucrose. So sucrose was the primary source of sugar in our diet, but as we introduced high fructose corn syrup into the diet, it displaced sucrose, and we started eating more and more and more high fructose corn syrup. Well, at the time when it was introduced, people had no idea that metabolically it was a unique substance that potentially could adversely affect health and well-being. In the United States, all of you are aware that we have this obesity epidemic that seems to have started about 1970 or 80, and the intake of high fructose corn syrup seems to nicely parallel the obesity epidemic. Am I saying that this is the single cause of the obesity epidemic? Absolutely not, but it certainly is a contributor, and we'll see how that works. Okay, so we also have started to, in the United States and the Western world, at one time in the 70s, we believed that cardiovascular disease was caused by a high-fat diet, high-saturated fat diet, high cholesterol, and so government recommendations told us to reduce the fat in our diet, and what we ended up doing is we ended up replacing the fat in our diet with carbohydrate from refined grains and refined sugar. And what ultimately happened was the glycemic load of the diet increased from 1970 to 2000, and once again, this parallels the change or the increase in obesity and overweight in the United States. So we did exactly as the government told us. We got the fat out of our diet, we got the cholesterol out of our diet, but unfortunately we replaced it with these high glycemic load carbohydrates. Now, if we look at cereal grains, up until about 1880, anybody that ate cereal grains or bread consumed it in this manner. It was made with these saddle stones. You can see this woman grinding up corn over here, or it was made with water-powered grindstones. And when they did this, they ground up everything. They took the wheat berry, they ground the entire thing up, and the flour that was used to make bread came from the endosperm, the germ, and the bran. And so this is called 100% extraction. The bread, the flour, the rolls were made with everything. Starting about 1880, steel roller mills were invented, and you can see them here and contrast them to a stone mill. And they fundamentally changed the way in which we grind wheat. So these things pulverize it, and they mix everything, the endosperm, the bran, and what ends up is the flour particle size is mixed. You have small, medium, large particle sizes, whereas when you grind the flour this way, it makes uniformly small particle sizes. And at the time, in the 1880s, we had no idea that this physiologically had a huge impact on our body and our health and well-being. And so, once again, with steel roller milling, it's very easy to remove the bran and the germ. Let me go back to the previous slide. And what happens is it squeezes the bran and the germ out, and you can sieve it off very, very easily. So what we end up with is the endosperm. We bleach it out, and this started, as I mentioned, about 1880, and we produced this very nice white flour of uniform particle size. So people thought that this was a good product. But unfortunately, physiologically, it was a very bad product when we ended up eliminating this and making these tiny little particles. And on this slide, what we look at is the flour extraction rate. So here's 100% extraction, meaning that the entire bran, germ, and endosperm are being used. And what happens as we extract more and more germ and bran, and we only leave the endosperm, what we can look at the glycemic index. And so up here, a whole wheat kernel in which it hasn't been ground has a very low glycemic index. If we just use the cracked wheat, it still has a fairly low glycemic index. But as we start to sieve off the bran and the germ and we make particle size of the flour that's smaller and smaller, notice what happens to the glycemic index. It gets higher and higher and higher. And that's the fundamental problem, is that high glycemic load carbohydrates from refined carbohydrates and sugars tend to promote diseases of insulin resistance. Now, this is an interesting slide, and this is a slide that was, or a study that was done in 1985, and at the time they didn't really have a clue as to what this slide meant. And what it looked at was the age of menarche in dietary fiber in 46 countries. So as people, as young girls, were consuming more and more and more and more fiber in the societies that they lived in, the age of menarche rose. As fiber declined and they were eating less and less and less and less fiber, the age of menarche was reduced. So at the time, the interpretation of this study was completely unknown because we had no idea of the glycemic index. The glycemic index was only 4 years old at the time, and the way in which the glycemic index impacted hormones was simply unknown. So this now makes sense in 2013 because very low fiber diets tend to be high glycemic load diets, and they tend to adversely affect the hormonal profile. So, conclusions. There has been an absolute dramatic increase in the glycemic index and the glycemic load. It parallels this increase in stature and reduced age of menarche, and the question comes up, is there a cause and effect between these two events, or is it just an anomaly, a statistical anomaly? Well, our research group was very much interested in this, and we believe then that high glycemic load carbohydrates are capable of producing a hormonal profile that promotes unregulated growth and promotes increase in stature and a reduction in the age of menarche. And I don't want to get into all the endocrine function here. Let's just give some real basics. The pancreas creates insulin. Liver secretes a couple other hormones. One is called free IGF-1, and another one's called IGF binding protein 1. So these hormones then influence how tissues respond in terms of growing or not growing. So let's just go back one, is that free IGF-1 here is a very potent mitogen. If you inject free IGF-1, it causes cells to grow. So when insulin levels are up, like they are when you eat high glycemic load carbohydrates, sugars, donuts, you name it, all the processed foods, when insulin is up all day long, which it is if you eat processed, refined carbohydrates, then what it does is it suppresses IGF binding protein 1, which in turn causes free IGF-1 to elevate. And when remember IGF-1 is a very potent mitogen. It stimulates cell growth. Then it tends to promote diseases that are associated with elevations in IGF-1. So a decade ago or even beyond, it turned out that if you look at obese children, what they ended up having, they were all insulin resistant. They had hyperinsulinemia. And not only were they hyperinsulinemic, they had a suppression of this one hormone, IGF binding protein 1. They had an increase in IGF-1. And look at these guys and girls. Not only are they fatter, but they're taller. So you want to produce a tall, fat child, make sure they become insulin resistant. So we've known for quite some time that IGF-1 has a huge effect on stature. And so here's a group of pygmies, and genetically they're very, very short because they have low IGF-1. And if we find children that are short shortly after birth, we can give them recombinant IGF-1, and when we do this, then we can make them taller. And adolescents that are insulin resistant are more sexually mature. And even in animal models, if you inject IGF-1, it increases the tempo of puberty. So if we look at, this is another hormonal profile, and I'm not going to bore you with this late in the evening. If you're interested, you can read my paper here that explains the biochemistry of it at my website. But insulin also tends to influence another hormone called IGF binding protein 3. And IGF binding protein 3 tends to inhibit growth and promote cell death, which is important in cancer. So when insulin goes up, it lowers this hormone that inhibits growth. All right? So that's an important point as well. This is and I don't want to spend a whole lot of time on this. This is a slide that we've shown examining how high glycemic load carbohydrates cause insulin resistance, how they cause elevated blood insulin levels, how this increases androgens. Androgens are male hormones, and how this tends to promote all of these other diseases that are associated with increased tissue growth. And this is the pathway that shows how unregulated tissue growth then results in all of these other diseases that I've talked about: myopia, nearsightedness, acne, epithelial cell cancers, breast, colon, and prostate, skin tags, polycystic ovary syndrome, and acanthosis nigricans. So if you're interested, you can follow through these pathways. We've explained it in this paper and others. Now, one of the interesting diseases that people hadn't thought was a result of insulin resistance was myopia, or nearsightedness. So if you look around the room and you see young people who are wearing glasses, almost invariably it's because they're nearsighted, meaning that they can see things close, but they can't see things in the distance. And so lo and behold, people that are nearsighted or myopes are taller than non-myopes. So the process that causes increased stature is the same process that causes nearsightedness. And lo and behold, myopes, females, they have an earlier age of menarche than non-myopes. Is this just a statistical anomaly, or is it the same mechanisms that's causing a greater increase in height, more myopia, and a lower age of menarche? So we've put this all together, and lo and behold, if you look at myopes or nearsighted people, they are fatter. Look at this. They got a greater BMI than controls. Well, what happens with myopia is the eyeball grows too long. So here's a normal eye, and when light comes in, it's focused right on the retina. In a myopic eye, the eyeball has grown too long. And so the question comes up is, what causes the eyeball to grow too long? And it was normally thought that it was just because of a blurred image. If you did too much near work, that blurred the image on the back of the retina, and that's what caused this to grow too long. More recent data now suggests that eating high glycemic load carbohydrates that cause insulin resistance is responsible not only for making these people grow taller, but for their eyeballs to grow longer and grow out of focus in front of the retina. Okay, the other disease that our group recently, not recently, but in the last decade, uncovered between insulin resistance and high glycemic load carbs was acne. And so when we look at acne, what is acne? Well, acne is a zit. You all know what it is. And how it results is, see these little cells right here? These are epithelial cells, and this is a pore. This is the pore, and there's a tiny little hair that comes out of the pore. When you get a pimple, what happens is these cells grow too fast, and they cover up the pore. They cover too fast, and there's a process called desquamation in which they slough off. And they don't slough off very good, and they kind of close this pore up. And then excessive androgens cause sebum from this pilosebaceous unit to flow into this area. It flows into the area, and it can't get out. And then we have bacteria on the cell surface that infect this area, and that's really what causes it. So the bottom line is what's going on here hormonally that causes these cells not to slough off normally, and what causes the sebum to be expressed in too great concentration. Well, it turns out that insulin resistance, the same hormonal cascade, increases IGF-1, lowers IGF binding protein, and it also adversely affects another hormone, which are the endogenous retinoids. So let's go to another disease. We're getting close to the end here, so hang on, and we'll get to the Q&A here shortly. I know I've been speaking for close to an hour, and I'm almost done. I'm long-winded. I'm a professor, but I'll get done with this, and then we can have an interactive period here. So polycystic ovary syndrome, these are women that have reproductive problems and involving the ovary, and this is they maintain a hormonal profile that is identical to what we saw with acne and what we saw with myopia. And if you look at dietary interventions, if you take women who are PCOS and you lower the glycemic load of their diet, lo and behold, they have elevated testosterone. So one of the symptoms of PCOS is hirsutism. They grow a lot of hair on their face and their body, and higher testosterone. All of this improves. And you can give them pharmaceuticals that improve insulin metabolism, and it tends to cause the same therapeutic effects. So by eliminating these types of food, M&Ms and ice cream cones and what have you in the diet, it seems to be therapeutic. Now, one other tie-in to bring this whole thing together, we're talking about all these other diseases of insulin resistance. If you look at women who have persistent acne in their adult years, I'm talking 30, 40, and even up in their 50s, they have an elevated risk for breast cancer. And we know from numerous epidemiologic studies that their blood concentrations of IGF-1 are elevated. And remember, how do you elevate IGF-1? Eat high glycemic load carbohydrates. We also know that insulin resistance is a significant risk for breast cancer, and sugar consumption is positively related to breast cancer mortality. So all of these pieces of the puzzle, if you connect the dots, seem to be pointing to the same environmental and dietary conditions. All right, let's look at tall women. Same thing like with tall men. We know that myopes, people that are nearsighted, tend to be tall. Tall women have an increased risk for breast cancer. They also have increased blood concentrations of IGF-1. And women who have an early age of menarche, say you had your age of menarche at 10 or 11 or whatever, it's going to increase your risk for breast cancer, and you also will have increased IGF-1 levels. IGF-1 also increases the risk for breast cancer. And we find this to be true in men as well. So tall men have an increase for prostate and other epithelial cell cancers. Both. So this is the hormonal profile that seems to be the bugaboo here, is if IGF-1 is elevated and IGF binding protein 3 is reduced, then it increases, whether you're a male or a woman, it increases your risk for all these cancers. Well, how do you do this? You get it by eating these foods. You think that whole grain breads are healthy? No, they maintain high glycemic loads and they cause this hormonal profile. These foods don't. You can eat these foods all day long and it won't do the same to insulin or IGF-1. Final disease, and we're almost done here, and then we'll get to the interactive part, are skin tags. And you've seen these if you've watched a relative or a friend or whatever, or if you've sat in a public forum and you looked at people that are slightly overweight, you can see skin tags. They produce themselves in the neck, in the armpits, in the groin areas. And what they are is they're an external manifestation of insulin resistance. So type 2 diabetics and people that are obese have these. It also increases the risk for cardiovascular disease. I'm not going to go through the pathway. It's the same pathway, so let's just skip it, other than to say that in all likelihood non-esterified free fatty acids and another hormone called epidermal growth factor are responsible. Final disease that is a disease of insulin resistance is a disease called acanthosis nigricans. You may have seen this, and it tends to affect people with dark skin more than it does light skin, and it's kind of this velvety hyperpigmentation. You see it around the knuckles. You also see it around the neck, the armpits, and the groins. It occurs frequently with PCOS. You can also see it on the neck of people. So this is not a normal situation. And in all likelihood, it is also a disease of insulin resistance. This is the logic that we've used. If you want to get the paper, go to my website. You can download it and read the mechanisms. But it certainly is a disease of insulin resistance. Finally, the last disease is insulin resistance in male vertex balding. Here's no balding. Here's Algor, and here's severe male vertex balding. This is the research from the group from Harvard a decade ago, and it shows that they also have higher testosterone, higher IGF-1, and lower IGF binding protein 3. They also have elevated androgen and reduced sex hormone binding globulin, which is the exact same profile that happens to women who eat high glycemic load carbohydrates. So in all likelihood, there's clearly a genetic component here, but there's also an environmental component, and the environmental component likely is high glycemic load carbohydrates. So what is the solution? How do we prevent or ameliorate these diseases of insulin resistance? This is what I've promoted over the last 20 years, is let's mimic the food groups that our ancestors ate with contemporary foods that are found in the supermarket. And you can see what they are: fresh fruits, veggies, grass-produced meat, seafood, healthful oils, nuts, and seeds. So thank you very much, and I'm going to end the show right now, and we're going to open it up to Q&A. So, Sue, you can take over, and I'll let you deal with it. So maybe I need to go over here. And
oh, okay, there I am.
All right, Sue, are you there?
Now? Yes, I'm sorry about that. Boy, I apologize to everyone for the technical difficulties. This is a new program for us, and although it went pretty well, we did have some issues, and I do apologize for that, and I do apologize for that beeping. We will take care of that for the next time. Thank you, Dr. Cordain. It was an excellent presentation, and I look forward to the replay, which we will be able to find at www.thepaleodiet.com. I would say within a week or so, Dr. Cordain, you'll probably have that posted. And,
yeah, I will. And those people that had audio problems, hopefully they can log on and get this whole thing in its entirety. And hopefully you can arrange that.
Yes, we'll put a note that will go out to the all the attendees, whether they attended or did not. and that will be in the follow-up email that lets them know that it will be available. So probably early next week sometime. So like I said, I, for one, look forward to it because I've been busy managing the technological aspects here, so I missed a little bit of it. We did get a few questions come in, and now would be the time for you to send questions if you have them. You can use your chat box or your Q&A box. And you can go ahead and send those in, and I will ask them to Dr. Cordain, and he will go ahead and reply to them. So let's get started with some of the questions that we did receive. Now, do we want to have the question and answer in the recording, Dr. Cordain?
I don't care. However you want to do it is fine with me.
Okay. All right. We'll leave them in because they're often very helpful for people. We got a couple questions on fruits, and I know you kind of summed up a little bit of that at the end, but somebody wanted to know, will you please differentiate fructose from fruit versus manufactured food?
That's a very good question, and if you go to my website, thepaleodiet.com, we have an icon called Nutritional Tools, and if you click on that icon, Nutritional Tools, we actually have that broken into the sugar content of fruits. And I've broken down perhaps 50 or 60 commonly available fruits in the Western diet, and you can see what the fructose content of all fruits are that you eat: strawberries, bananas, grapes, apples, and so forth. And so I think that will be helpful for people that are interested in if you eat fructose from fruit versus manufactured fructose to see how much fructose you're actually getting. And the bottom line is that you're getting an order of magnitude higher fructose from candy and soda pop and any food that's made with high fructose corn syrup than you are from fruit. However, nevertheless, is that if people are overweight and insulin resistant, when they first start out on a paleo diet, they should stay away or should significantly reduce fruits that are very high in fructose, and those are apples, bananas, grapes, and others. And if you go to my website, you can see what the high fructose corn or the high fructose fruits are. Fruits that have little fructose are melons and berries.
Okay, and we had a related question about fruit and type 2 diabetes with obesity, wanting to normalize blood sugar and lose weight. Should they eat any fruit at all?
I think everybody has to kind of listen to their own body, but to my way of thinking is high fructose fruits, and again, go to my website and look that up, should be very, very carefully evaluated in people that have type 2 diabetes or are overweight. Now, there are some fruits that contain virtually no fructose, like, for instance, avocados, and some citrus fruits like lemon and what have you. So there are some that have virtually no fructose in it, and if you go to the website, you can see that. But what you should stay away from, as I mentioned, are like grapes and apples and bananas and those kinds of things that are high in fructose. And until your type 2 diabetes normalizes or your overweight and obesity normalizes, I would recommend trying to consume more and more vegetables and less fruits, and only those fruits that are tend to be low in fructose. Tomatoes also are very low in fructose, so they're a good one.
Okay, we're getting a lot of great questions come in. Somebody also wanted to know, if I eat a paleo diet, do I need to take other vitamins, omega-3 and omega-6 supplements?
I think when you start off, it depends. Many people that adopt a paleo diet have been doing the typical Western diet for 20, 30, 40 years or their entire life, and so they're depleted or replete in a variety of nutrients, and one of those are long-chain omega-3 fatty acids, DHA and EPA. So if you've been eating a typical Western diet with grains and processed foods and junk and very little fish or grass-produced beef or other meats, then you're almost invariably, your fatty acid profile in your blood cells and muscle cells are going to reflect that bad fat that you've been eating. So it's a good idea, I think, to take fish oil for the first few months or so as you try to normalize your metabolism. So that would be the one supplement that I think many people, particularly if you don't like to eat fatty fish, that would be a good idea. And I myself do take fish oil. I think that you should consume not cod liver oil, but the oil from the fish body itself, because cod liver oil contains kind of a weird profile of the vitamin D and vitamin A that seems to adversely affect vitamin D metabolism. So I think that fish oil is one supplement that people should take. They should take roughly about, and if you eat fatty fish, like a quarter-pound serving of salmon will give you about 1,200 milligrams of EPA and DHA. And if you eat that much on a daily basis, you're going to be in great shape. If you eat fatty fish 3 times a week, you'll still be in good shape. But if you don't eat salmon, you don't like it, you don't like sardines or halibut or mackerel or other fatty fish, then you probably need to take a fish oil supplement. The only other supplement that I would recommend would be vitamin D, unless you're a lifeguard or an outdoor worker living at equatorial latitudes where you can get sunshine day in, day out. Most of us in North America and the United States have day jobs where we work inside, and it's impossible to get sufficient sunlight over the course of the year to keep our blood concentrations of vitamin D in levels that we need them. So a good recommended amount is 2,000 IUs of vitamin D3. The governmental recommendations of 600 are a joke. You can't take, if you've got low blood levels of vitamin D and you take 600 IUs, which is the government recommendations, and you draw your blood for the next 6 months, it won't move. It won't change at all. So you need to take at least a minimum of 2,000 IUs and perhaps as high as 5,000. Work with your practitioner, a clinician, or a physician. Monitor your vitamin D levels. And healthy vitamin D levels are above 30 nanograms per milliliter on up to 50 or more. So the real health benefits occur when you're up over 40, 45, or 50 nanograms per milliliter.
Okay. What about the glycemic load of slow fermented whole grain sourdough breads? Would these be acceptable in small amounts?
You know, I think everybody kind of has to use this paleo diet concept as a starting point for optimal health and well-being. And, you know, humans don't have a grain requirement. We can get everything we need without grains. We're happy and healthy without grains. So if you want to eat grains, it kind of partially reflects an addiction to these foods that we've been eating all of our lives. And it's a triage type situation, and people do much better by replacing grains, whether they're fermented or however you want to produce them, with fresh fruits and vegetables. So if you have to have grains, go out and do it once a week or once a month or whenever, but you're much better off by eating healthier living foods.
Okay. What about your position on the volume of raw versus cooked?
Well, you know, that kind of begs the bigger issue is, when did humans or hominins control fire? And the best available evidence suggests that in Europe it may have happened by about 300,000 years ago, whereas in the rest of the world maybe even later still. And so controlling fire is no easy thing. And actually making fire is the big deal. So when did we have the ability to start and stop fires? Well, we could go out and we get a lightning strike, or an area where there's a volcanic eruption or other naturally spontaneous occurring fires, but that was few and far between, and it was a hit and miss deal. So you had to keep the fire going essentially year in and year out. It was very, very difficult during rainstorms and whatever have you. So until humans actually could generate fire themselves, did we actually have control over it. And there is some evidence to suggest that Neanderthals may have been able to control fire, but the best available evidence is that humans controlled fires through fire drills, which came even later still, maybe 100 to 60,000 years ago. So if that's the scenario, then our species essentially ate food raw. Is that the best way to do it? No, that's what we were left with. So we know now that eating raw meat has a serious number of risk factors involved with it in terms of E. coli infection and other parasites. So what we need to do is we need to take the best of our ancestral world and use it and leave the worst behind. And one of the worst was the non-realization that there were infectious agents that caused multiple diseases. So hanging around animal meat that's raw and intestines and parasites, and then consuming that and putting it in our bodies is not a very good idea if we have ways to get around it. So cooking with fire tends to reduce that risk. And it also, with plant foods, it makes certain elements in plant foods that have toxic compounds less toxic.
Okay. What about blending fruits or vegetables in a blender? Does that cause any detrimental effect on the benefits for health?
I don't really think so. One of the problems is if you juice fruits or you juice vegetables, like making carrot juice out of carrots, it removes all of the fiber and it gives you a gigantic blast of sugar that has a similar effect on our blood glucose and insulin as soda pop does. Now, it's got a ton of great phytochemicals in it, so there's no doubt that carrot juice has that. And I think that you can blend, if you have a vegetable juicer, you can blend vegetable juices and produce juices that don't have excessive sugar. So you put in a little bit of a carrot, some celery, and some other vegetables that don't have a lot of sugar, and you can make a pretty healthful juice. So if you look at like V8 juice, it's a commercial thing that comes out of a can, but it comes in a low sodium version. If you've got yourself a juicer, look at the ingredients and make the same kind of juices. Tomatoes are very low sugar. Throw in a tomato or a carrot to give it a little bit of flavor, a beet, some celery, and what have you, and you can produce a pretty healthy juice. So throwing vegetables and stuff into a blender, if you keep all the fiber in it, is still another way to go.
Okay. And also got a question. What is your position on the influence of environmental toxins, particularly endocrine disruptors on the body? My reading has led me to believe that these toxins in foods, plastics, and personal care products are as much to blame as diet.
I'm right with that, the reader or the listener. I'm absolutely on board with that. And if you go to my most recent book, The Paleo Answer, we talk about plastic, components of plastic that get into our environment that we don't even know about, plastic bottles, plastic liners on food, and hormones that enter into our environment because we put hormones in our feedlot. It gets into the water supplies, on ad infinitum. So unfortunately, we live in the 21st century, and it's difficult to escape this, but there are a variety of behavioral tactics you can do to reduce these hormonal disruptors or hormonal promoters in your diet and your environment. And in my most recent book, I talk about where you can get water that tends to not have these, and how you can filter water, and how you can buy products in the supermarket. If they're in glass, you're in a lot better shape than if they're produced in plastic. So if you're going to buy olive oil, buy it in glass rather than plastic. Those kind of things. So.
Okay. We're getting a lot of great questions. It's hard to kind of keep up with them, so I apologize if I don't get to your question. Here's something you might want to clear up for a lot of people. I've heard that if you follow the paleo diet, the quantity of food doesn't matter as long as the quality is there. Is that true?
Pretty much. That's been rule one from the very beginning, is that no animal on the planet thinks about calories, and no animal, tends to overeat on a chronic basis. So my feeling has always been is eat until you feel full, and then those feelings, when you feel full, you stop. When you eat real foods, your normal appetite and apostat and the hypothalamus of your brain tends to stop things when you're full. When you eat broiled salmon and steamed broccoli, there's only so much you can eat. You just stop when you're done. Whereas, a Mars bar or chocolate candy or ice cream, you can eat and eat and eat and eat, and 20 minutes later you still want to eat more. So I think that appetite is self-regulating, and when you eat contemporary diets that mimic the food groups of our ancestral diet, you don't really have to pay a whole lot of attention to how much or how little you eat. You need to be sensitive and aware of your body and the signals that it sends you. And frequently, if you've been overweight or obese and you've been eating a typical Western diet, you are so tuned out of your body and the signals that it's sending you that you frequently are trying to reproduce the signals that you used to get when you're eating white bread and whatever with real food. But once you get a few months into it, I think that people become sensitized to real food, and their taste buds become sensitized, as do the rest of their physiology. So it's a self-normalizing situation.
Okay. And what about meat? I have a question here that someone says he feels that he heard you say that any amount of saturated fat from meat is okay to consume. And how do you reconcile that viewpoint against the literature which tends to show reduced cognitive capability in humans, mice with large saturated fat intake?
Well, I think that the point is well taken, and this is an area that, as a scientist, I've had trouble with over the course of my career, and I try not to waffle, but I think that the starting point for healthy human diets is with this Paleo paradigm, and clearly, high saturated fats in our ancestral diets would have been difficult. Not saying that it couldn't have been done, and not saying that they didn't absolutely go for saturated fats, but we've done those analyses in wild animals, North American and African animals, and wild animals are lean. They are way leaner than what animals that you get in the feedlot. And we actually published a paper, and you can go to my website, and it was published in 2005 or 2006, in which we analyzed the saturated fat content in hunter-gatherer diets. And in the U.S. diet, the authorities, the American Dietetic Association, the American Heart Association, the USDA, they all recommend that we consume less than 10% of our calories from saturated fats. Well, saturated fats, there's 4 major saturated fats, and I don't want to bore the listeners, but they all have slightly different effects physiologically. However, when we looked at the analysis for hunter-gatherers, there's no hunter-gatherer on the planet who got less than 10% of their calories from saturated fats. It typically was between 12 and 17%. So that seems to be the norm. And when we did the analysis, the types of saturated fats that they consumed were evenly split between palmitic acid and stearic acid. So when this reader asks me the studies with animals, I have to first see that study, and I'd have to see the percentage specific types of saturated fats. So the best available evidence tells us that the evolutionary template is generally correct. And the evolutionary template tells us that if you get 12 to 15% of your calories from saturated fats evenly split between stearic and palmitic acid, then it probably has virtually no effect or adverse effects on health and well-being.
Okay. Boy, like I said, the questions just keep coming in. It seems that a lot of them, I think, can be answered from on your website, Dr. Cordain, and that is www.thepaleodiet.com. This presentation has been recorded and will also be available for replay on that website. So let me see if I can find one more question here that kind of...
Yeah, let's do one more and then kind of try to wrap it up, Sue, because I know that, I'm a college professor, and I know that the average attention span of most people is about an hour, and we're running at about an hour and a half. So let's maybe do one or two more, and then we'll call it an evening. And I want to thank people that have hung on for so long, despite some of the technical difficulties. And I'd like to meet.
Okay. You talked a lot about menarche. So what is the normal age considered for menarche today? And in addition to that, those severe sugar cravings that many people get prior to their period, any suggestions for that? We had several questions on that.
Well, I guess it's kind of like what is any physiologic normal? If you look at blood pressure, in the United States, we consider a normal blood pressure to be 120/80, but that's only in the United States. If you go to South American countries, we look at the Yanomamo people, who are a non-salt eating population. Their blood pressure is 100/70 or 100/60, and it doesn't rise at all during life. So what we might consider to be normal in the Western world is really physiologically an anomaly. And I think that what is normal, what humans have evolved with over the last 2.5 million years. So if we can get to non-Westernized populations, then those values that we find in non-Westernized populations are normal. And so, as I had mentioned in my talk, it looks like the normal age of menarche in a hunter-gatherer society is age 16, whereas in the Western world, the average, kind of like the average blood pressure, is around 12 or slightly lower than age 12. So what it tells me is that menarche at age 12, from an evolutionary perspective, is very abnormal. And the second part of the question is cravings of sugar and so forth prior to a period. I think that periods are hormonally driven, and food actually changes androgen and estrogen levels, and we know it does in both males and females. So both males and females produce these hormones, and I think we simply don't have enough randomized controlled trials to look at high glycemic load carbohydrates and say how they potentially adversely affect androgenic and estrogenic hormones. But my feeling is that they do, and the dots haven't been completely connected. One thing that I can tell the listeners and readers is that if you do have amenorrhea, no periods, dysmenorrhea, or oligomenorrhea, painful periods, women who go on Paleo report that their menses return to normal. Women that have for years have had painful periods return to normal, and women who have not been able to ovulate and have children can have children. And similarly, men that have low sperm counts seem to be helped with this diet because it's a high zinc diet. We know that low zinc levels in the diet tend to adversely affect sperm counts. So both men and women who are trying to and have children, paleo diet is good therapy.
Okay. Well, I think we're going to end on that note because we are a little bit over our 20-minute question and answer period. So I thank you again for your excellent information, and I want to thank our listeners for joining us this evening, and also remind them that a lot of your questions can be answered at www.thepaleodiet.com. And also remember that you can get 10% off the Paleo Diet Platinum membership when you use the promotion code ANA Paleo13. And that promotion will expire on the 31st of October. So be sure to check it out, www.thepaleodiet.com. And I thank you all again for joining us. I apologize once again for the technical difficulties and the beeps that we had, but we will remedy that for the next time. Thank you again, Dr. Cordain, for joining us and for your very excellent information.
Good night to everybody, and thanks for participating.
Good night.
Good night.